So, we are set and we go now from here. Good evening, everyone. I am Siddharth Paramhans from Waypham India. As you know, like Waypham is an eye care company with focus on eye hygiene and eye health. And it's great pleasure welcoming our great audience across country, many viewing from internationally also. We are live right now on YouTube and Facebook. So there are many people who have joined there as well. I'm very happy to welcome all our panelists, guest faculties today. Some of the very renowned people have joined us today, and an expert on the subject of blepharitis, MGD, dry eye, and overall ocular surface disorders. And among our faculties, we have Dr. Ashok Grover, Dr. Kuresh Maskati, Dr. Tushar Grover, Dr. Aditi Agrawal, Dr. Jaya Gupta, Dr. Arun Baveja, and Dr. Hitendra Ahuja. Now, from the perspective of this program, Waypham Academic Forum is hosting this webinar, Why Knowledge of Blepharitis, MGD, Dry Eye is Essential for Post-Lockdown Practice. It's a very interesting topic for discussions in current scenario. The epidemiology data suggests that almost 1 out of 3 patients, there are 32% patients in India, they are visiting eye doctors suffer from ocular surface disorders like blepharitis, MGD, and dry eye. And especially elderly people, the problem is even high. And more importantly, like Demodex mites are one of the key cause of blepharitis in India, often underdiagnosed, and at times the level of awareness is also quite missing. Hygiene and preventive care is a need of the hour in most patients. Also, dry eye continues to be very bothering and frustrating problem for many of the patients, especially with the increased users of mobile, laptops, and all screens. So in modern management, there has to be thinking beyond lubricating drops. And I think this webinar will ignite a lot of discussion thoughts among the senior faculties present with us. And I'm sure that it's going to be one of the very interactive webinar. It's going to be very participative webinar as usual that our experience is. I request now Dr. Baveja to please introduce our panelist. Dr. Grover is Padam Shri and Dr. Kuresh Maskati from Mumbai. So we are very lucky to have both of them with us. And I'll just put a brief introduction slide. And Dr. Baveja, please introduce both of our panelists.
Thank you, Siddharth.
Just a minute, sir.
Dr. Grover needs no introduction. I think he's been a teacher of teachers, and I've had the pleasure of working with him twice or thrice. In fact, he's the chairman, Ganganam Hospital, Mission Eye Center, and Padam Shri awarded by President of India. He's the president of South Asian Association of Ophthalmic, Reconstructive and Oculofacial Aesthetic Surgery, past president of Asia Pacific Society of Oculoplastic and Reconstructive Surgery, AIOS Oculoplastic Association of India, and a very, very dynamic and talented surgeon. He's taught everything to everyone.
Can you also please introduce Dr. Kuresh?
Dr. Kuresh Maskati, I've known him for a few years now. He's been president of AIOS, he's been president of International Society for Manual Small Incision Cataract Surgery, president Cornea Society of India, president Bombay Ophthalmic Association, and president Maharashtra Ophthalmic Society, and chairman FBS AIOS currently. And a multifaceted man, very, very interesting to stay in company.
Thank you very much, Dr. Arun Baveja. And maybe request Dr. Grover to have start off this program today, Doctor, and have a few words, please.
Thank you, Siddharthji. It's a pleasure to be a part of this webinar organized with the help of Waypham. And as you said, this is a subject that concerns us all. And it is the problem that overshadows any other in our clinics. And this is the commonest cause for which patients turn up to us, the ocular surface problems. And the more we know, the more we realize the importance of these subjects. The meibomian gland disease particularly is a problem which is so common amongst the people aged over 40 and above that it really alters the clinical picture of so many other diseases as well. So it's important in the COVID times or any other times to understand this disease well. And we're really lucky to have a very talented group of speakers who are going to speak on it. And nothing could be a greater joy than having Quresh Muscati as a co-panelist. I'm sure he'll keep us all happy with his great sense of humor, which we all have learned to appreciate over the years. So we look forward to a great session. I request Quresh to speak a few words, and then he can start with the introduction of the first speaker.
Yeah. First of all, thank you, Ashok, and Arun for your kind words. I have a confession to make. Since I'm not feeling very humble just now, the title concept is mine. And the reason why I chose this particular title is that post-lockdown, many of us who start our practice post-lockdown are unlikely to be flooded with patients wanting cataract surgery yesterday. So we are going to have a surfeit of patients who in these 2 to 3 months of lockdown have had many problems, tiny, small problems, niggling problems, problems like irritation in the eye, problems of the overuse of their computers, problems of lack of hygiene of their eyelids and face. And all these are the patients who are going to suddenly flood our clinics. So we are going to see a surfeit of these, and it will be very sad if we misdiagnose or underdiagnose these in the post-COVID era, because these are the patients who are going to ultimately bring their parents or whatever for cataract surgery when the time is right. So we need to treat our walk-in patients who will come once we open up. Some of you have opened, some are yet to open, some will open tomorrow, some will open according to the astrologer. But whenever we do open, we will need to pay much greater attention to the problems of the ocular surface than we have done so far. So we need a primer webinar, which will prime us how to suspect, how to look for, right from history to simple examination techniques to sophisticated equipment if you have or do we need really, and then get down to treating them so that we have happy patients at the end. I think we have an excellent panel. I don't want to come between me and the panel. So we'll start straight with our first speaker, Dr. Hitendra Ahuja, who will be introduced by Ashok.
May I have the slide, Siddharthji? So Dr. Hitendra Ahuja is a consultant in Gurgaon. He runs the Ahuja Eye and Dental Institute, and he's also associated with the Waypham Mahindra Nirmaya Eye Bank. He's the president of the Gurgaon Ophthalmological Society, a very active member who has been very dynamic, has organized a number of meetings. He's also associated with the North Zone Eye Bank Association. And he has been a pioneer in improving upon several surgical procedures in the entire state and in the country. And he's an invited speaker at most of the important fora in the country. So we look forward to Dr. Hitendra Ahuja speak to us on this subject.
Thank you, sir. Thank you, Dr. Grover, for that kind introduction. I'll share my slides now. And thank you, sir, for having me here. I'll be talking on blepharitis and how it affects the ocular surface disease. Am I clearly audible, sir? And the slides are visible?
Oh,
Yes, yes.
Make it full, yeah.
Yeah. Okay, sir. So, as said by Dr. Grover, that it is the large number segment of the public is affected by blepharitis associated symptoms, and it has been now a published fact. And most of these patients present in our OPDs as the irritation or watering in the eyes, commonly known as khujli pani. And to our experience, when we checked our data, the scenario was the same as published and as known by everybody. And to look the same thing in a different perspective, as said in this article, blepharitis is the most common cause of watering in the patient who present with epiphora and have the patent syringing. So if we look at the definition of the blepharitis, the term blepharitis encompasses the condition that result from pathology associated with the pilosebaceous unit of the anterior lid and the meibomian glands of the posterior lid. And going to the classification, it can be classified as the anterior and the posterior anatomically, and infectious and seborrheic according to the etiology. And we will be looking at these entities in details in the subsequent slides. And as we have talked that most of the patient present as watering or the irritation in our OPD, it can also present as the crust or flakes on the eyelashes or the sticking together of the eyelids or the redness on the eyelids. These are also the presenting complaint that patient can present with. And this is how the seborrheic blepharitis look like when we examine the patient on the slit lamp in our OPDs. There is presence of erythroderma. The eyelashes are often greasy. There is presence of matting of the eyelids and dandruff. Yes, we should look for when we suspect a patient to have a seborrheic blepharitis. Uh, Patient can also have erythema of the upper and the lower eyelid, and it can often be associated with rosacea uh, in the form of papules, pustules, or the rhinopama, and it is known to get aggravated with tea, coffee, spicy food, and alcohol. And now the infectious blepharitis, uh, it can be associated with hordeola. Then we can see this lid edema, and the patient often presents with the pain as the main feature, and the discharge in the in and around the lids can be in the form of matting of the eyelashes. There it can be seen as the collarets or the scaling of these eyelashes. All these three basically the discharge can present like this. Talking about the meibomian gland dysfunction, when we examine on the lids on the slit lamp, we see this blocked orifices on the posterior lid, and when we press these lids, there is a release of foamy discharge after this after lid pressure. So dysfunction can have thicker and rounded lid margin. It can have trichiasis, dystrichiasis, medrosis, hyperkeratinization, excessive foam, and decreased number of gland orifices. And this is a very new concept being talked about by a Japanese group, which are talking about how to differentiate aqueous deficiency dry eye or the evaporative dry eye. What they are saying is if there is a area break or the line break, then we should uh, see the look for the aqueous deficiency causes. And when we see a random pattern of the breakup time, the cause mostly is the evaporative dry eye. So this can also help us when we are examining the patient of MGD, because then we are looking for a evaporative dry eye and not the aqueous deficit dry eye. And the meibography and all the investigations, this can tell us the gland dropout, and Dr. Tushar will be talking about it in detail, so I will not uh, talk here about the ocular surface analyzers and things like that. And when we are examining a patient of blepharitis, we should be also knowing about this entity, what is known as Demodex, and it is basically the causative agents is Demodex follicularum or brevis, and the risk factors who can get affected are the patient who have rosacea, immunocompromised patients, or patients who are chronic alcoholic smokers, or stress has also been kind of correlated with this kind of blepharitis and with any other disease that we see. So it can have direct damage to the follicle, hair follicle. It's a vector for bacteria, and it can also lead to hypersensitivity reaction by the debris and the Demodex. And finally, what it can lead to is the trichiasis, madrosis, malalignment of the eyelashes, blockage of the orifices, swelling, enlarged glands, lid margin inflammations, and blepharoconjunctivitis, corneal lesions like flictins, and if it turns to be a chronic thing, then the opacities or the even the nodular scars. This is how the classical Demodex blepharitis that has been explained as the cylinder dandruff at the root of eyelash. So if we see this kind of a picture on the slit lamp, we should suspect Demodex, and how to investigate and further thing will be talked in the subsequent uh, uh, part of the session. I'll not cover it here. So blepharitis can lead to increased tear evaporation. It can lead, yes, then hyperosmolarity, and this is how it leads to ocular surface damage. And the pro-inflammatory mediators are released, and it leads to reflex tearing, and the patient presents to us with complaints of watering with the patent syringing. Just to give you a example, this patient presented to us, 77-year female, with the complaints of redness, watering, blurring of vision in both eyes since few days. And when on examination, she had a severe infectious blepharitis, she had a marginal keratitis, she had a hypopion. And we were kind of not very sure that blepharitis could lead to this kind of a picture, but when we went through the literature, there were few case reports which said that yes, severe staphylococcal marginal keratitis had presented with hypopion, and even some of our fellow consultants were suspecting end off and were ready to go ahead with the intravitreal injection. But this patient was nicely treated with oral antibiotics, topical steroids, and the cycloplegics. Another example, this patient, 50 years female, who presented to us with redness, watering, irritation in both eyes since 1 month, and she had history of similar episode in the past and had received multiple drugs in past. And when her lids were examined, she had posterior lid margin blepharitis, conjunctivitis, punctate keratitis, flictonules, and marginal keratitis and ulceration. And this patient was managed by doxycycline, antibiotic, topical steroids, and azithromycin eye ointment. And there is enough literature to support that oral azithromycin has a great role to play in blepharokeratoconjunctivitis conjunctivitis in adults as well as in children. So now talking about the management of blepharitis, if we see this infectious blepharitis, If we are saying that it is suspecting a bacterial, we need antiseptic, lid cleaning, topical antibiotics and corticosteroids, and oral antibiotics for if there is a presence of secondary hodiola. And if we are suspecting a virus etiology, then oral acyclovir and acivir eye ointment. And if we are suspecting some parasite, the manual removal can be of help. And Demodex, I'll not talk here. Dr. Jaya is talking about in detail in the subsequent part of this session. And to tell about the seborrheic blepharitis, warm compresses help a lot. Baby shampoo in the concentration of 1:5 helps to get relieved of this seborrheic blepharitis. Then antiseptic lid cleaning and oral doxycycline is antimicrobial and inhibits matrix metalloproteinases that degrade connective tissue. Given for a long time, maybe month, 2 months, helps a lot, because these are all chronic condition, and can be this doxycycline helps a lot. Meibomian gland dysfunction, there are various modalities of diagnosis now available in the market, like LipiFlow, and to manage this intensive pulse light therapy. Dr. Tushar will be taking us all these things in detail, and we'll love to hear from him, and I'll not cover it here. Thank you. Over to you, sir.
Thank you, Hitendra. Thank you, Hitendra. That was a very nice overview of all the various affections of the eyelid. We have now learned that there is more to it besides a stye and a chalazion and some blepharitis. So there is many things to it, and everything has its own nuances in treatment. Everything is not treated with a hammer philosophy. So you need to diagnose, you need to look very carefully at the eyelids. Unfortunately, we have been trained for our bread and butter to put a patient on slit lamp and look straight to see whether he's got a cataract or he's pseudophakic. If he's not pseudophakic, we go ahead with advising cataract surgery. So it's best to spend some time from the outside inside. Start with a simple torchlight examination to look for rosacea and rhinophyma, and then take the patient on the slit lamp and start looking at the external surface, the eyelids, the eyelashes, as Dr. Hitendra has advised. I invite Ashok to introduce the next speaker, Dr. Tushar Grover. I take great delight actually in asking Ashok to introduce the next speaker.
Quresh was talking about examining the adnexa. He forgot the people who only examine adnexa like me.
Yeah, I sympathize with you, Ashok.
Of course, we do look at the surface. So as Hitendra was emphasizing, there are a lot of secondary effects on the eye, and which include the keratitis, which include the non-healing ulcers, which include the bacterioallergic keratitis, which I think is often an underdiagnosed or misdiagnosed condition, and the effects of exaggeration of computer vision syndrome because of meibomian gland disease. Those are things which often get neglected or not get noticed. So important is not just the diagnosis, but the secondary effects that those are having on the eye and the other diseases around the eye. So it's my privilege now to introduce Dr. Tushar Grover, who's a director and consultant at the Vision Eye Centers in New Delhi, and also a consultant at Sir Gangaram Hospital, New Delhi. He's not mentioned in the slide, but he's also a management alumnus from the IIM Bangalore for the medical professionals. So he's done that course. So he's won various awards with his videos, with his papers at various fora, and he has presented and written research papers, again presented in various parts of the world and published in reputed journals. So He has a special interest in the field of cornea, refractive surgery, ocular surface, and cataract. So we look forward to him speak on this subject of Meibomian gland disease.
Tushar, is this the first time that you've been so introduced?
Yeah, I think so.
Okay, good.
Pretty formal introduction. Good to hear that. So thank you so much for having me. I'll be talking about Meibomian gland dysfunction, and I'll be going through some of the current perspectives when it comes to diagnosis and management. So we know that over the last few years, there has been a considerable increase in the understanding that we have of dry eye, and that has led to a much greater scientific interest in the disease. What we also know now that about 60% of the patients that present to us with dry eye have Meibomian gland dysfunction. So they have dry eye secondary to Meibomian gland dysfunction, and about 10 to 15% have a mixed component. This is the vicious cycle of dry eye that has been described. Dr. Hitendra also spoke about hyperosmolarity, inflammation, tear film instability playing very important roles. So what is important here is that any of these etiological agents can lead an individual into this vicious cycle of dry eye, which then self-perpetuates and carries on even if you've removed the original agent that got the person into this cycle in the first place. And of course, Meibomian gland dysfunction is at the core of this. So in this cycle as well, you can see proliferation of bacteria in the flora of the eyelids and the conjunctiva, which produce lipases, esterases, and other digestive enzymes and fatty acids that increase the melting temperature of meibum. And that subsequently leads to the blockage of Meibomian glands and further on to dropouts and atrophy of these glands. And inflammation also plays an important role, which leads to keratinization of Meibomian gland orifices, again, leading to the same outcomes. This is what leads to an unstable lipid layer, subsequently translating into too much evaporation of tears from the ocular surface, leading to a dry cornea and subsequently dry eye. So when we're evaluating a patient with Meibomian gland dysfunction or with any form of dry eye for that matter, it's always best to start from the most non-invasive investigation to the most invasive one, because each investigation that you do subsequently has an impact on the next one. An important tool that I like to use in my practice is the OSDI questionnaire. There are a lot of other questionnaires available as well, and they're validated and equally good, so you can use those as well. The important thing with questionnaires is that you're able to document how symptomatic the patient is in the first place when the patient comes to you. And then when you start your treatment, you can monitor over time and see how the patient is responding to the treatment that you give them. I'll be talking about some of the specialized tests that are available. I'll be talking about the benefits and the drawbacks of each, and I have no financial interests in any of these. So the first one that I'll be talking about is the Tear Lab Osmolarity Kit. So the TFOS DUCE2 report has also stressed a lot now on tear film osmolarity, because it's a much more objective measurement of dry eye. So somebody who has a high osmolarity value has more severe dry eye. So this is an instrument that gives you that measurement. The disadvantage and the drawback here is that the repeatability is an issue. Sometimes you do the same investigation in the same patient after some time and you'll realize that the value is a little different. So that is where, for me, this instrument is not up to the mark in that way. Inflammadry is another important kit which is available now. What this does is it detects MMP9 levels in tears. So this is basically telling you if there is inflammation in the eye. Based on this, you can decide if you would like to include steroids or other anti-inflammatory agents in your treatment regimen. So the drawback for this is that this is going to tell you that there is inflammation in the eye. This will not be telling you if there is inflammation in the eye because of dry eye or because of something else. It could even be VKC or maybe even an infective conjunctivitis. So that is something that you have to see and clinically decide. The other important tool that we use in our practice routinely is now the LipiView 2, which basically uses interferometry and visualizes the lipid layer of the tear film. In addition to that, you also get the blink dynamics and you get imaging from the Meibomian glands. So what you see here is on the left side is an individual with a very healthy looking thick lipid layer where you have a lipid layer thickness of more than 100 nanometers. On the right, what you see with this blink is an individual with a much more dull looking lipid layer, and the lipid layer thickness here is about 39 nanometers. So this is somebody with evaporative dry eye, and this is somebody that you would like to treat on looking at these interferometric images. Also, you get these images of partial blinks. What this is able to tell you is that if there is a high ratio of partial blinks, you might want to give a lubricant gel or ointment because the tears are not getting distributed too well in this particular patient. So this patient might benefit from additional lubrication or lubrication that lasts a little longer in the eye. And these are meibomian gland images that you see. What you see on top here is an individual with relatively normal meibomian glands. So there is some amount of tortuosity here, but otherwise not much dropouts. However, when you look at the individual below, you see there is a huge amount of dropouts of glands. So this is somebody who's likely had chronic and very long-lasting meibomian gland dysfunction. There is also a meibo scoring that has been proposed depending on the degree of dropouts that exist, and you can score the eye from score 0 to score 3. And when it comes to managing meibomian gland dysfunction, the aim of the treatment becomes to break that vicious cycle that I had spoken about. So each intervention that we take acts on different components of the vicious cycle, and some on multiple components of it. So for example, oral tetracyclines would act on the inflammation, and in addition to that also reduce the bacterial load that exists. And steroids again would target the inflammation. Lipids would help take care of the lipid layer deficit, and lubricants and lid hygiene also act on different parts of this vicious cycle that needs to be broken for us to be able to bring back the homeostasis of the tear film. Warm compresses and manual lid expression do form the first line of the treatment, and they do play an important role. But the issue that exists with warm compression is that you are applying heat at the external surface of the lids, whereas the meibomian glands exist closer to the inner surface of the lid. So even if you are able to maintain sufficient temperature at the external surface, you do not necessarily get that at the level of the meibomian glands. So that is where the LipiFlow or the vector thermal pulsation system helps, because it has these cups which you place in the palpebral fissure, and the heat is applied from the inner surface of the eyelid, and you get pressure pulsations from the external surface. So it's a 12-minute cycle. You can see the pressures and the temperature slowly building up, and subsequently at the end of the procedure you get a report of the treatment having been done. So there are quite a few RCTs available as well now, which have found that vector thermal pulsation is more effective than warm compresses, both in terms of objective measurements of dry eyes as well as the symptoms of patients. A very genuine drawback here is the cost. It's a pretty expensive procedure, and you cannot really offer it to all the patients. In addition to that, if somebody has a huge amount of gland dropouts, then you really need to counsel the patient well, because the benefit that patient is going to get from LipiFlow or from any treatment for that matter is not going to be very, very significant, because there are already a huge number of glands that have been lost, and those glands don't come back. There are certain other modalities available as well that play an important role, such as these eyelid heating masks. So what you see here is a USB based heating mask, and the person sits comfortably with the controls in his hands, so he can adjust the temperature depending on what is tolerable to him. And if you look at the graph on the right side, you see that the different masks that have been shown, all of them are able to get reasonably good temperature profiles, at least at the external surface of the lids. And when you look at the red line, that is what is a face cloth. So definitely not getting the right temperatures there with the face cloth as compared to these masks. This is another instrument which is available, which is called the Meibo Thermoflow, which again provides heat from the external surface. And you do see symptomatic improvement in patients with this as well. But the limitation with both the things that I just mentioned is that you are applying heat from the external surface and not from the internal surface. So there is not much data that compares all of these modalities. There is one small study that I was able to find, and in that it is mentioned that LipiFlow is able to get better temperature profiles at the level of the meibomian glands, but there is more literature that is needed on this. Another modality that is catching on and becoming extremely popular now is intense pulsed light, because this was originally used for rosacea and other skin conditions, and dermatologists had been using it, but it has now been found to be effective in MGD as well. So this provide bursts of light at specified areas of the skin. And it basically helps by reducing the vasculature around the meibomian glands, which reduces inflammation and also plays a role by the heat that it provides. So that is also another factor. However, when the original publications by Toyos and the original group had come out, they had stated that this is not really known for its efficacy and safety in the pigmented population. So for us, for our population, which is primarily pigmented, we need more data to really see if it is effective in our scenario. So to conclude, meibomian gland dysfunction is an underdiagnosed and undertreated entity, but extremely significant and extremely common, causing dry eyes in a lot of patients. There are a whole range of new diagnostic instruments that are available now, and it is really up to the practitioner to see what is more relevant in their practice, and also in terms of the cost settings. There are a whole range of treatment solutions that are available as well now. Some have been there for longer and have more literature to support their efficacy and safety, whereas some are more recent and need to be looked at a little more closely. So thank you.
Thank you, Tushar. The audience is brimming with questions. So we'll take some questions for Hitendra first and then for Tushar.
Sure.
Hitendra, one question is blepharitis contagious? If a patient has blepharitis, do you want to isolate them from other family members, or if it's a child, not send them to school? And what, in your opinion, is there a one-stop treatment for every blepharitis?
Yes, sir. Definitely, if it is an infectious blepharitis, that can be contagious. And if it is a seborrheic blepharitis, then it is not contagious.
Okay. And can blepharitis result in vision problems also?
Yeah, if it leads to corneal complications, then definitely it can lead to vision problems.
Yes, I think you showed it in a couple of slides also of how a blepharitis and a meibomitis was the actual cause of repeated eye infections.
Yes.
And what would you say is the one thing that a general ophthalmologist must keep in his armamentarium for treatment of almost all, let's say, anterior blepharitis?
I think warm compresses is the way to go. The patient should be basically asked to maintain the lid hygiene.
Right. Tushar, is everyone at risk of meibomian gland disease? One of the slides mentioned that if you're in the elderly age group, almost everyone. So is that really true in our scenario? And if you get MGD, can you come out of MGD, or is it like diabetes? You're stuck with it, Tushar?
Yeah, with the elder age group, there is a higher risk of you getting MGD because there are multiple factors for that as well. The sex hormones and the decline in androgens and the change in the estrogens, all of that has been found to play an important role. So the exact reason why age increases, with increasing age, there is increasing prevalence of MGD is not completely known, but yes, age is definitely a risk factor. And as far as the treatment is concerned, yeah, you are mostly trying to provide symptomatic relief and improve the function of the meibomian glands, but it's not something that you can cure, especially if it has been long-standing already.
So that's greatly to the benefit. Just like how the skin specialists love treating the skin because you don't really cure anything. Yeah. Similarly, you can keep the patient permanently with you. Is that, Tushar, what you're implying?
Yeah, the patient does come back pretty often. So the patient is not going forever. That you can be sure of.
Another advantage dermatologists claim is that he's not going to die of the disease, and he's going to remain troubled all his life. So.
Tushar, another question from the audience is, how do I know if my meibomian glands are blocked? Is there any way that the patient themselves can come to know, or is it a diagnosis always made by the eye surgeon?
So the symptoms that an individual would have would be consistent with other forms of dry eye as well. So it would be on clinical evaluation that you can be sure that an individual has dry eye, on meibomian gland expressibility and other clinical investigations. So for an individual, it's difficult to tell.
Yeah. So see what separates from the men from the boys, as it were, as far as eye surgeons is concerned, is that if you're an average eye surgeon, you will tell the patient that he or she has got dry eye because he complains of dryness, irritation, burning.
Yeah.
And something like that can be done by the chemist down the road as well. But if you have really listened to the webinar and Tushar's talk, you can know that for every patient who complains of dry eye symptoms, you will look at the eyelids and you'll pick up MGD in more than 50% of the cases. Tushar, in your opinion, what is the chief etiology of MGD in what you've seen? Is it just age or is it others?
The most common that I see is age. There are a lot of other factors as well, but age is definitely the most common factor that you would see.
Okay.
Just a couple of questions to Tushar. You mentioned a plethora of diagnostic tests. Which ones are most useful for a general ophthalmologist if you were to choose one or maybe two? Second, you mentioned about a lipid layer replacement. How do you do that?
So there are, I'll talk about the lipid layer replacement first. There are lipid supplementation lubricants that are available internationally, but unfortunately, that is not available as of now in India. So Cystane also has a variant which comes with lipid supplementation, but unfortunately, we don't have that available in India as of now. And they keep saying that it's coming out soon, but hasn't yet happened. And as far as the diagnostic instruments are concerned, yes, nothing replaces a good clinical evaluation. Meibomian gland evaluation by mechanical, this thing should be done essentially. And additionally, for me, what would be most important is any interferometer. There is LipiView is one of them, but there are a lot of others as well, which can look at the lipid layer using interferometry. So LipiView is extremely good, but it's also a little more costly as compared to the others. There are others which are less expensive also, but that adds value to my practice along with a meibography. These two, I think, for diagnosis.
Yeah, also simple autorefractors. Many of them have got, you just flip it open and use the infrared because you got infrared light there. You can see it. You may not be able to photograph it as elegantly as you could on a meibography machine, but you can see it for yourself quite easily. Yeah.
Thanks, Quresh and Tushar.
Yeah. Shall we go on to the
next one? Yes, please.
Yeah. Siddharth. Can we go to the next? Thank you. Okay.
Quresh, go ahead.
Yeah, so it's my pleasure to introduce Aditi Agarwal. She did her training as a cornea fellow from the LVP Institute, and then not sure of what she really wanted to do, trained in glaucoma from Arvind. But more and more she's inclined towards the ocular surface, I'm glad to note, and she's been spending a lot of time and taking more interest in the ocular surface, lamellar transplants, and has other things up her sleeve, which we won't go into now. We'll concentrate only on sharing her expertise in the ocular surface with us. Thank you, Aditi.
Yeah, thank you. I'll just start my screen share. Just give me a minute. Is the slide visible, sir?
Not yet.
Not yet. Just give me a minute.
Yes.
Okay. Very good evening. Thank you so much for having me here. I would be speaking about some interesting cases related to the eyelid disorders. So what we intend to discuss in the next couple of minutes is first and foremost is to quickly brush through one of the key takeaways from the Tear Film Ocular Surface Society DUCE 2 report, which actually very nicely showed us an easy 4-step diagnostic approach, and then to see how best we can apply it into our clinical practice to some practical case scenarios. Also, how should the mind exactly work when a patient of suspected dry eye enters the clinic? So one of the key takeaways from this report was essentially a 4-step diagnostic approach. The first step was basically the application of some triaging questions, doing a risk factor analysis, exclude conditions that may mimic dry eye disease. Then the step 2 was basically with the use of some validated questionnaires like dry eye questionnaires or the OSDI questionnaires. And this, along with one of the homeostasis markers, comes as the step 3, where you use primarily the non-invasive tear film breakup time, osmolarity, and ocular surface staining. And finally, step 4 is where you apply some subtype classification tests so that you can actually classify the condition, whether it is on the evaporative severity spectrum or is it more on the aqueous deficient severity spectrum. As we know that it's not a clear-cut distinction now between the evaporative and the aqueous deficiency dry eye. It is more of a spectrum, and one could lie anywhere along the spectrum. So important to kind of apply some tests to see on what part of the spectrum is your case or your patient actually falling into. So as Dr. Muscati also mentioned, Dr. Ahuja also mentioned, first step is basically step back from the slit lamp, observe the external appearance and look for facial signs. It's very, very important. We just jump onto the slit lamp and start seeing, we might actually miss many things. So look at the lids carefully. The next step would be look at any lag of ophthalmos, any infrequent blinking. Look for the eyelids, any floppy eyelids. Is there any lid retraction, ectropion, entropion, trichiasis, dystichiasis, and others. Look at the lid margins. Again, very important. Dr. Tushar very well mentioned about it. Dr. Ahuja also spoke about the meibomian gland architecture, the openings. Look for blepharitis. Look for telangiectasia. Again, plays an important role in certain kinds of MGDs. And look at the position and the size of the puncta. Conjunctiva, look at it. It may show some redness. It may show some evidence of early keratinization. Look at the tear film. Look at the meniscus, presence of foam or debris. Inquire about any contact lens usage, ocular allergies, any history of any surgeries in the past. And of course, go into the medical history of autoimmune diseases, diabetes, thyroid eye disease, any history of radiation, etc. So let's straight away go to some few case scenarios because I think we've had a good discussion on the theory part in the last two speakers. So let's see how we can get our patient from this to something really pleasant and makes him smile and then go back. So this was a 28-year-old female, quite worried and stressed to be engaged in the next 3 months, complained of severe burning sensation, pain, heaviness, and puffiness since the last 6 months. She used all possible type of lubricants. Currently, she was on hyaluronic acid-based lubricants. So the approach, yes, the initial complaint suggestive of dry eye. So take a comprehensive history to identify the exacerbating factors and patient behavior. So she did have a history of PCOD, though she was not on any treatment for the same. She was a heavy computer user, no other significant history. And of course, while speaking to her, taking the history, you could see how her skin looked like. She had a lot of facial erythema and a few acne, which was observed. We used the dry eye questionnaire and the score was around 9 on that. So on examination, the lids showed MGD2+ with a lot of lid margin telangiectasia. The conjunctiva did show tarsal congestion. The tear film breakup time was around 6 seconds. There was some few punctate epithelial erosions on the inferior cornea. Schommer's was around 15. So this was classically a case of moderate dry eye with rosacea and MGD. So in this case, the treatment obviously is very, very important to look at the lids. Warm compressors with the lid margin scrubs with an antibiotic steroid combination. The tea tree oil-based lid cleansers that we heard about previously. A short course of topical steroids to reduce the inflammation. Oral doxycycline in such cases plays a very, very important role. What I typically like to use is, initially 100 mg twice a day for 2 weeks, and then taper it to once a day for another 2 to 3 weeks, depending upon the response. Also, oral omega-3 fatty acid supplements, yes, they do play a role. But though, as per the latest news to report, they say that it's probably debatable. It could be a placebo. But nevertheless, I guess we have seen responses with this therapy, and it's better to go ahead with it. So she was advised also for a dermatology and a gynecology review in view of her PCOD. At the 1-month follow-up, she was significantly better. The tear film breakup time was around 12 seconds, did show some improvement. The lid margins improved, and we asked her to continue the warm compressors and artificial tears. This was a patient, 27-year-old female. This is a short, simple case, more relevant for comprehensive general ophthalmologists, so that we don't miss out on these kind of infiltrates that we see very commonly. So she had a similar history of pain and photophobia 2 months back. On examination, the lids showed mild anterior and posterior blepharitis. The conjunctiva also showed localized congestion at the limbus at around 10 o'clock, corresponding to this area, just around this area on the conjunctiva. And the cornea revealed a single gray-white anterior stromal peripheral infiltrate separated from the limbus by this 1 millimeter clear zone, and fluorescent stain was negative. Anterior chamber was quiet. There was no evidence of any facial erythema or any cutaneous features suggestive of any rosacea. Careful examination also did reveal a previous a nebular scar here. You can see adjacent to this infiltrate, this area, also suggestive of a previous similar episode. So the diagnosis was a kind of a catarrhal ulcer or a microulcerative PUK secondary to blepharitis. Primary treatment here, of course, we know is suppression of the immune response with topical corticosteroids like loteprednol or fluorometholone. Treat the associated blepharitis to suppress the staphylococcal colonization of the lid margins. Again, tea tree oil-based cleansers and wipes do have a role to play, and lubricants. This was an interesting case. This guy was a 30-year-old male who came to us with extreme redness, watering, and photophobia for the last 3 days. He gave similar history, similar complaints, recurring history almost every couple of months over the past 2 years. Every time he was treated with moxifloxacin eye drops, but he said he never really improved and it kept coming again and again. The left eye was the one which kept having these problems, and he had a history of myopic LASIK done in the left eye only. No history of any other contact lens wear or trauma or swimming, and no diabetes or any other systemic condition. Now in this we see that the cornea revealed, an epithelial defect around 2 by 3 millimeters located inferiorly around say 6 o'clock with some folds in the LASIK flap. It was a superficial, quite vague looking corneal infiltrate with few pinpoint lesions. Anterior chamber that did show some occasional cells. So we went ahead with a diagnosis of microbial keratitis in this case, with differentials being probably acanthamoeba or nocardia, looking at the LASIK history and the appearance with some pinpoint lesions. However, the microbiology did not reveal much. The gram stain was just suggestive of few GPCs and few non-specific bacilli, which was negative. So we treated him empirically with fortified cifazoline and ciprox. He improved at 3 weeks. There wasn't any infiltrate, no epithelial defect, and he scarred. So we thought, fine, I guess probably, we've done well and we've achieved what we wanted to. But this didn't stop at this point. Exactly as per his previous history, he came back with similar complaints and similar findings again after 3 months. Corneal scrapings were negative again. So now is the time to re-examine this patient with an open mind. We saw significant anterior blepharitis. This time it was much more. At the previous episodes, he never had this extent of blepharitis. We plucked off an eyelash and observed under the microscope. And of course, this is what we saw. So it was the Demodex. And this is what probably we missed in the last visit and was also missed by other practitioners probably over the last 2 years. And now knowing the importance of Demodex, I am sure none of us are going to miss this and going to pay much more attention on this. Dr. Jaya would be covering the Demodex in detail in the next presentation. So I won't be going into the treatment modalities for this patient. And this is the last case. Basically, this is a patient where we tried everything, all possible kind of things. We could not really understand what is really bothering her. And finally, this actually turned out to be probably a patient of neuropathic pain. Again, an entity, which is not very well understood, but probably we need to get into the details of the pain pathway and all to understand. So this was a 44-year-old female who had redness, significant pain, and mild photophobia for almost a year. She was on Cysteine Ultra and Cyclosporin for the last 1 year again. She did have a history of MGD, but she was very uncomfortable with hot fermentation and refused to do it every time. So the initial complaints did obviously be suggestive of dry eye. We did take a comprehensive history to identify the exacerbating factors and also patient behavior. What is the psyche? Is there any anxiety? Is shown any antidepressants? Many kinds of things might actually affect your diagnosis, and very important to look into these. So there wasn't any systemic drug history, no topical drug history. She wasn't on any hormone replacement therapy, not a contact lens user, no eye surgery. She did have a history of hysterectomy quite early in life, around 25 years back. She did have a history of some dry mouth with lower back pain. We did do an immunological workup also, but everything just turned out to be negative. So this patient had just some MGD. The tear film breakup time was 8 seconds. Shermer's without anesthesia was around 13 and 12 respectively in the right and left eyes. So overall, she didn't look too bad. She was not as per her complaints. It just looked like a mild to moderate dry eye. Lid management was important. We did advise her with all the treatment, but obviously she wasn't comfortable with warm compresses. We gave her some lid margin scrubs with an antibiotic steroid combination ointments, a short course of topical steroids. Wanted to give her oral doxycycline because she did have a significant amount of MGD then, but she wasn't tolerant as per her history. Oral omega-3 fatty acid supplements, she refused. She said she has severe acidity after she consumes it. So what we were left with is essentially lid scrubs with some antibiotic steroid ointment, preservative-free artificial tears, cyclosporin eye drops. We also tried abapamide for some time, but she didn't tolerate that as well. We got her to go through her immunology workup, and everything just normal. At 2 weeks follow-up again with all this treatment, she wasn't really happy. Her parameters were almost the same. We added some additional gel-based lubricants, continued the preservative-free artificial tears again till the next review. Next 2 weeks again, status quo, very unhappy. Got a vitamin B12 and vitamin D levels also done because they also do contribute in these kind of patients. There was a little decreased observed, and so she was put on the right supplements. But her pain just kept on continuing. And it was very interesting that she would only come with a complaint of pain. We would see her cornea was quiet. We would not see any erosions. Her MGD appeared to be better with the antibiotic steroid ointments, but her pain would really never go, and it still continues. So probably there are these small subset of population who would not respond to practically, anything and everything. Yes, they are a big challenge to us because they are going to be those unhappy patients going from one doctor to other and, unfortunately not being treated. Pain was always the main complaint in her case. Probably it's a neuropathic pain, quite a under-evaluated feature of dry eye, probably needs a little more attention, little more reading probably. We need to understand this entity much better. So the management of a dry eye disease, I feel, is actually like an art. It's not just like ABC, you do this. You have to see many factors, take a lot of things into consideration, look into the psyche, also look at the psychological behavior, and then try to see what best steps you can take and how do you counsel the patient right. There is no single rigid evidence-based algorithm, which can accommodate all the patients. You would have such exceptional cases. All eye care providers must exercise their clinical expertise to judge the significance of each of the contributing pathogenic process. Whether it's aqueous deficiency primarily, is it MGD, how significant is the inflammation? Many a times we have seen patients with dry eyes, if you do give them a short course of corticosteroid eye drops, even for a short time, they start improving, and then you can always shift them to the non-steroidal anti-inflammatory or maintain them on that. Always hear your patient with patience. I guess that will work wonders for both. Thank you so much for your kind attention.
Thank you, Aditi, for a lovely case-based presentation. Just a couple of comments. Almost your last sentences, you did mention something like steroids, short course, and then non-steroidal anti-inflammatory. Have you tried any NSA? It's an audience question. Any NSA in any blepharitis work?
You mean as the first step? You mean as the first step before having
after steroid? No. You said I would give steroids a short course and then shift to NSA.
Yeah, so actually what I probably meant by the non-steroidal was the cyclosporin group of drugs actually. Not the
NSAIDs, not the bromphenic.
Yeah. Not the NSAIDs. In fact, I have seen these patients do very bad with these drugs. They are highly irritant.
I just wanted to emphasize.
Correct.
Exactly. I just wanted to emphasize exactly what you're saying now. Is that NSAIDs like bromphenic and nebuphenic should not be used in cases of dry eye or in blepharitis. They have no role, and sometimes they do worsen the disease.
Yeah, true.
Also, coming to your case number 4 and then case 1, I'll just talk. Case 4, where you mentioned the neuropathy and the pain. One of the drugs that tends to help a little bit is the topical chloroquine drops. So those with photophobia as a symptom, those with pain as a symptom, seem to do well with about a 2-month course of topical chloroquine, maybe about 3 times or so a day. The other thing in these patients is there is often a psychological component to these. This lady, poor thing, at the age of 19 or 20, if my maths is good, underwent a hysterectomy, which is a huge psychological blow to a young lady, and maybe never really came out of this. So sometimes they have anxiety, a little bit of depression, which tends to exacerbate this pain or makes it more functional. So sometimes you need to spend, either become a good counselor yourself and spend a lot of chair time with the patient, or you need to refer it to a psychologist, or I wouldn't say a psychiatrist, but to a psychologist. I have the benefit of my wife being a psychologist, so I do send them across, and I've had patients really improving with this, because they go a little deep into the history and just counsel them.
Oh, that's nice.
The first patient which you talked about, the with query rosacea, the young lady, again, there one thing that we need to ask for is history in youngsters with acne is of tretinoin use, because many of these patients are on skin creams by dermats or by chemists which contain tretinoin, and tretinoin tretinoic acid is something which worsens the dry eye and an ocular surface disease. So when you're dealing with people with acne, do ask a question about tretinoin and try and get them off the skin creams which contain tretinoin. Excellent, Aditi. Yeah.
Thank you. Good. So I'll try and hunt for a good psychologist or a clinical counselor. Or I come to Mumbai. I belong to Mumbai basically. I'm from KM. So
thank you.
I better come back to Mumbai. Bye.
We'd like to compliment you for your cases, because they were all very representative. And the first three were definitely medical problems. And I second Quresh when he says that the fourth case is where your axiom of treating the person rather than treating the eye is very important.
True, true.
And a couple of words in line with that, a sympathy with the person, looking at the overall life. You yourself can do that job of encouraging the patient. You don't really need Quresh's wife to do that.
Yeah, true.
Thank you, Aditi.
Okay, thank you.
We'll go on to the next presentation by Jaya, and then we will take questions together. So Jaya has been in practice in New Delhi, and she's a consultant cornea and refractive surgeon. She did a fellowship at Shankar Nethralaya in Chennai, and for some time was a pool officer in the cornea unit at the RP Center. I invite Jaya to tell us about something which is just emerging as a problem. We always knew a little bit about Demodex, but we thought it's a commensal, just like you have bacteria in your mouth and you have bacteria in your eyes which you live with, and they live with you and they don't cause any harm. We thought that diagnosing Demodex is no big deal. They're there, so what? But we are learning more and more about this peculiar organism and the harmful effects it has in our eye. So I invite Jaya to tell us a little more about the Demodex and the different types of Demodex that we have. Jaya.
Thank you, sir. Thank you for the kind introduction. I start with my screen share.
You'll have to open it on your screen and then start screen share. Come out of screen share now.
Stop.
Open. Yeah, stop screen share. Open the PowerPoint on your laptop or whatever, and then start screen share.
Is it not visible?
Not yet.
Not yet. You'll have to come out. Yes. Quit screen share. Open your PPT, then start screen share. Minimize it, open it, minimize it, start screen share.
Is it visible now?
Excellent, excellent. Go ahead.
Okay. So thank you, sir, for the kind introduction, and thank you, organizers, for letting me speak on Demodex Blepharitis, which has been briefly discussed by both Dr. Ahuja and Dr. Aditi. So at this point, I'll say that we all know that tiny mites live in our eyelashes. Yes, this is called Demodex. It's the most common permanent ectoparasite in humans, belongs to the class arachnid, order Acarina, and Demodex, the word comes from demos, wax or fat, dex, insect. And we have two species, Demodex follicularum, which is primarily found at the base of eyelashes, and Demodex brevis, which inhabit the meibomian glands. But what this paper also says is that these Demodex, they actually help keep your eye clean. So let me take you to a few clinical scenarios. This is a 19-year-old female with multiple episodes of red eyes. Frequent prescriptions of steroid eye drops has been given to her, and this is her clinical picture. Our next case, 25-year male with recurrent red eyes since the last 10 years. And this is what we are seeing in the clinical picture, marginal keratitis with corneal neovascularization and conjunctival inflammation. Our third patient, a 25-year male, again with recurrent red eyes for the past 2 years. So is it a case of mistaken blepharitis entity? Is it most commonly it would look like a staphylococcal marginal keratitis. But why are we talking about this? Because the patient has had multiple recurring episodes since 2 years, since 10 years. Hence, we must consider other causes. Classically, a textbook description of staphylococcal anterior blepharitis would be yellow crusty collarettes on the lashes, whereas in Demodex, we see, as the arrow points, clear gelatinous waxy debris at and surrounding the base of eyelashes. This is called cylindrical dandruff, and this is pathognomonic of Demodex blepharitis. Not essentially that, that in the absence of cylindrical dandruff, we would not be diagnosing Demodex, but if there is a cylindrical dandruff, it is pathognomonic of Demodex. So I show you a small video of Dr. Geeta from my mentor in Shankara Netralia. How do we look for Demodex? We epilate the eyelashes, two non-adjacent eyelashes from each of the two lids is epilated, put on a slide, a cover slip put on top of it, a drop of fluorescein is placed. This fluorescein helps to dissolve the cylindrical dandruff or whatever debris, and then it is seen on the microscope. We start with lower magnification 10x, in which it is easily visible. These are some of my own pictures which I've captured from with my cell phone of my own patients. Like I mentioned, there are two species which inhabit human beings. Demodex follicularum, which is slightly longer, 0.3 to 0.4 millimeter in length, and Demodex brevis, which is slightly shorter, 0.15 to 0.2 millimeter in length. It's invisible to the naked eye. It has a semi-transparent elongated body that consists of two fused segments. 8 short segmented legs are attached to the first body segment and the tail behind it. The 8 legs of this mite move at a rate of 8 to 16 millimeter per hour. From a study from South India, the incidence of Demodex infestation was seen in 90% cases of anterior blepharitis, 60% in MGD cases, and 90% in mixed blepharitis, 18% in the control subjects. Like Dr. Ahuja had also mentioned this, the rate of Demodex infestation increases with age, being observed in 84% of the population at age 60 years, 100% of those above 70 years. He also discussed the 3 basic pathogenic mechanisms of lid irritation, which is the primary symptom of Demodex infestation. First is direct damage, that is the biting apparatus of the mite alone. The second is lipolytic enzymes produced by the parasite to digest the sebum, and by the accumulation of parasite excreta, resulting in blockage of sebaceous glands that may lead to infection or the stimulation of the host humoral responses and cell-mediated reaction. Third is secondary or concomitant microbial blepharitis. The microorganisms, most commonly streptococci, staphylococci, they may cling to the integuments of the parasite, and this is the secondary vector damage, like it acts like a vector. The Demodex-induced changes to the cornea is basically a spillover of inflammation from anterior and posterior blepharitis. It may cause superficial punctate keratopathy, corneal neovascularization, stromal and marginal infiltration, flectinular lesions, superficial opacities, nodular scars, limbitis, and perforation. From a very recent published paper on Demodex keratoconjunctivitis, a retrospective review of 14 patients, the median age was 27 years, range being 11 to 39 years. The symptom duration was 2 months to 20 years, rosacea in 3 patients. The common misdiagnosis was allergic conjunctivitis and viral keratitis. Cylindrical dandruff was present in only 6 patients. The rest had clean eyelashes. Inferior superior vascularization was seen, corneal scars in 12. There were 4 steroid-related complications. All except 1 responded to tea tree oil, and 13 were off steroids after 3 weeks of starting treatment. The treatment given was 50% tea tree oil lid scrubs along with 2 doses of oral ivermectin. Besides, Demodex has also been implicated in the causation of chalasia, pterygium recurrens, rosacea, where Demodex is inhabiting the facial skin, floppy eyelid syndrome, also eyelid basal cell carcinomas. The treatment of Demodex consists of weekly lid scrub with 50% tea tree oil diluted in olive oil. This tea tree oil comes from, it's a natural essential oil, steam distilled from Australian native plant Melaleuca alternifolia. Along with this weekly lid scrub, we give daily tea tree oil applied to the eyelid in the form of scrubs using eyelid wipes, which has 7% tea tree oil, or foam, which has 2% tea tree oil. These tea tree oil treatments for at least 2 Demodex mite life cycles we give, that is approximately 6 weeks, in order to ensure adequate killing of the parasite. The terpinen 4-ol is the most active tea tree oil molecular compound against Demodex. Oral ivermectin, 2 doses, 200 microgram per kilogram, 1 week apart, is also given for treatment. So tea tree oil, besides this, also has antibacterial properties against methicillin-resistant Staph aureus, antiviral, herpes simplex and influenza virus, antifungal, Candida albicans, anti-inflammatory properties as well. So what does it do? It basically interacts with the cell membrane of the bacteria and the fungus, disrupting it, causing altered permeability, leakage of cytosolic contents, and inhibition of respiration, leading to bacterial or fungal death. Also, it stimulates the human monocytes to release TNF-alpha interleukins that is responsible for the anti-inflammatory action, and superoxide production decrease in the reactive oxygen species, and that is responsible for the antioxidant action. The tea tree oil stays long on the skin for 4 hours. And this is a short video again by Dr. Geeta showing in-office tea tree oil treatment of Demodex, where tea tree oil and olive oil is mixed in equal ratio. This tea tree oil is easily available from Body Shop, Khadi, and etc. stores. After instilling a drop of paracaine with a cotton tipped applicator, it's gently scrubbed along the lid margins. Fortunately, most of the time we don't need to resort to such extensive lid scrubs. With the easy availability of Oculeaf eyelid wipes and Oculeaf lid cleansers, we can give them to our patients with the instruction of using it twice daily. And this helps tremendously. Thank you.
Thank you, Jaya. Jaya, a question from the audience. If you do find Demodex, you found it, how will you further counsel the patients? And do you counsel only the patients, family members? Is it likely to be in the family?
So it can be.
Jaya?
Yes, sir, it can be. It can be contagious. That is definitely there. But even if in my practice, even if I don't see Demodex, even if I have not isolated, but it's a chronic recurring problem, then I do give them these eyelid wipes and cleansers. I do advise lid hygiene with the eyelid wipes and cleansers.
How would you decide which patient goes in only for the Oculeaf lid wipes and for whom you have to prepare this olive oil and 50% TTO?
So if we have isolated the Demodex mite, if we have isolated and the patient, the red eye is not going with the steroid antibiotic combinations, then I would like to give them the in-office tea tree oil scrubs.
So in effect, you will try the Oculeaf first, and if it doesn't work and you're sure of your diagnosis, then you would go for the 50%.
Yes, sir. Absolutely.
Okay. There's some questions from the audience for Dr. Aditi. What causes the thickening of eyelids and how can I hydrate my eyelids? We know how we can use teardrops to hydrate the ocular surface, but is there some way to hydrate the eyelids, Aditi? Can you wash your eyelids? Will that help?
I think she's been muted actually. They might have to unmute her.
In the meantime, we'll ask for Siddharth, can you help getting her unmuted? Yeah. Jaya, in the meantime, is there any way that you can see Demodex clinically on the slit lamp, or do we have to pluck an eyelash every time?
I think the ocular surface analyzer which has come, it has got an attachment with which you can see the Demodex. We have the ocular surface analyzer, but we don't have that extra attachment. So I've not been able to see onto the slit lamp on this OSA. But besides this, there's also a technique described by Mastrota et al., in which they gently pinch and pinch the eyelash out, rotating it. And they say that sometimes the tail end can be visible on the slit lamp. I don't know. I've tried it.
One supplementary.
Yes.
For the benefit of the audience, how many cases do you see per month so that they have a perspective on how well they should be, how commonly they should be looking for it?
Dr. Arpan Gandhi also want to have.
Sir, can I take that question if Dr. Jaya allows?
Yeah.
Yes, sir.
So I had two things to comment. One is we started this about a year ago. We've seen about 100 cases. Initially, the awareness was less, but in the last 6 months, we started seeing more Demodex cases. A lot of younger adults coming in who are mainly males is what we are seeing. And a very important tip, if you're going to see the Demodex yourself, is just don't look near the eyelashes. Scan the whole slide. I have seen cases right on the cover slip, right at the edge, sitting there. So just don't go for the eyelashes, because Demodex brevis is something which usually, we published a latest paper on IGO, though we haven't given this into publication, but I have seen cases where Demodex has been reported as negative, but actually the Demodex has been very motile and has gone right to the edge. And sometimes you even need to put 2 cover slips because it just kind of nearly goes away from the slide. So that's a little tip for people who actually wanting to see it. As JR demonstrated very nicely on the Dr. Geeta's videos, it's a very great thing to do. But this is just a little small tip I wanted to give you from my experience on seeing these cases.
Thank you, Dr. Gandhi. I think that gives us a perspective that it is a disease which frequently gets missed and should be looked for much more critically. And we should be sending many more eyelashes to you. Dr. Gandhi, just for the audience, is a very eminent ocular pathologist with the Shroff Eye Hospital in Daryaganj. And he's done a lot of work in ocular pathology and related aspects.
Is Aditi with us now?
Yes, I am. Can you hear me?
Yes, Aditi, there were some questions from the audience for you. Is there,
Correct.
just like you have teardrops which would hydrate your ocular surface in dry eye, is there anything like something which we can use to hydrate our eyelids? Would washing of the eyelids frequently help?
I would not suggest washing eyelids frequently, because what I have seen is washing eyelids frequently or washing eyes frequently sometimes tends to pull out the natural moisture. So probably once or twice may be all right, but frequent washing I'm not in favor of. Second thing is, what I have seen is, if you can warm compress your lids, once a day, maybe even just for 5 minutes, it definitely helps to release all the inspissated, those lipid secretions. And it does give you a good feel on your eyelid margin. So it may be a kind of a lid hydration.
Aditi, can you just expand a little, because when I talk to any group of 10 people, 10 eye surgeons about warm compresses, all 10 of them have different concepts and give different concepts to the patient.
Okay.
Some of them say, I've heard them say, take a towel, bath towel, and when you finish a bath, just wash it in the shower and rub your eye with the towel. And some people say there is give warmth separately and compress separately. So could you just elaborate for the audience what exactly is warm compresses?
Okay. So I will like to share what I like to follow practically in my practice. Step 1, hot fermentation is, first you take some water. We want moist heat because we know that moist heat works better. So moist heat is better than using dry heat. That's one. So second thing is, what you will do, you take a bowl of hot water. The temperature of the water should be as hot as the eyes can comfortably tolerate. So this is different tolerance level for different individuals, but hotter the better. Second step is, you can use a fresh, a clean cotton cloth, a muslin cloth, or maybe a small Turkish towel, maybe a small napkin. Just fold it, dip it into the hot water, give a squeeze, have a nice hot towel which is ready now. Close your eyes, keep it on your eyelids, on the eyes, and keep pressing on the eyes. Give some nice gentle compressions all over. Your pressure should not be too harsh, but it should not be even like you're just touching. It has to be a little pressure which goes onto the lids. Following this, I find it a good idea to have some lid massage, which you could do with your finger alone. Have a nice clean finger, wash your hands. After you've done the 8 to 10 minutes of hot fermentation, the way I just said, the second step is to kind of milk out the secretions. The secretions now have got liquefied, you need to milk them out. So you can use your finger, keep the eyes closed. Now the stroke has to be firm but gentle. It should not be harsh, but it has to be firm, along with some gentleness in it. So I like to do it as the meibomian glands are located from top to down. So this is basically like milking out the secretions. So you go all over, and this is for the upper lid. On the lower lid, you could try, look up. So the aim is to try and milk out the secretions towards the orifices which are on the lid margins. Post this, you could use a cotton or any cloth dipped in water and just cleanse it properly. And once it's nice and clean, and if you've been advised an antibiotic steroid combination ointment, you may apply that on the lid margins. If it's just a mild case and we don't see that much of inflammation, you can stop there. And typically doing this at least twice a day would definitely help.
Excellent. Thank you. I think this was very useful tip for everybody, because everyone otherwise advises patients differently. And
True.
then the patient comes to me saying that, I've already been doing this warm compresses for 2 months and it hasn't worked. And invariably I tell them, please tell me exactly what you're doing. and
Absolutely.
describe it with actions, and then I get aghast at what is happening. So thank you. Are there any more questions from the audience that we haven't answered? As far as I think the speakers have answered all of them. Can we then go on to our next speaker?
I'll ask one question in the
Go
meantime.
ahead.
You spoke about the use of doxycycline in the management. There are some studies which would suggest that azithromycin used much less frequently may be equivalent. What do you think of it? Would you use azithromycin just 3 days for 3 months, or any of the equivalent therapies? And is it clinically as efficacious?
So what I have seen in my practices, generally doxycycline has always worked much better for me in my patients. Azithromycin, somehow I have not seen the response that I would want to. I have used them in a couple of patients, but when I didn't see the desired response, I wanted to shift to doxycycline alone. And ever since that, I have only been using doxycycline, and I feel it works amazing. It gives very good results.
Ashok, what I do sometimes is that I will give them a single 500 milligram azithromycin tablet and then follow it up with doxycycline for 3 months, as Aditi has recommended. Important thing with doxycycline is you need to tell them to take it on an empty stomach, because that works best. And you need to tell them that this is for 2 months or 3 months, because when I prescribe doxycycline for 3 months, the chemist has countermanded my prescription, saying that your doctor was in a hurry. It's an antibiotic. He must have meant 3 days. Don't take it for more than 3 days. So patient comes to be a month later who's been on doxy only for 3 days instead of 3 months. So you need to tell the patients to ignore what the chemist says, because sometimes they feel they know best.
Also, I guess it's very important.
Yes, Aditi.
Sorry. I just wanted to add that it's very important, like many of our patients, of course, they are all learned and, they read a lot and they come. So they themselves know that they say, oh, it's an antibiotic. I think it's important you have to tell them that it's actually an antibacterial and not an antibiotic. And there is a difference between the two. So bacteriostatic versus bactericidal. So we are dealing with something which is different. It is not really an antibiotic. And that's why it needs to be given on a long-term period, so that it can go and take care of the chronic condition.
I also tell them, Aditi, that it's a side effect of the doxycycline, which is because they are so convinced it's an antibiotic. So I tell them there are side effects of the doxycycline which are beneficial to your eyelids. We won't go into the details, but please take this for 3 months. Yeah. Ashok, you were saying something.
The other thing that gets underemphasized is the association with rosacea. And it is particularly true in us, where facial erythema is hardly discernible because of our nice pigmentation on the face. So that's the reason why I think even dermatologists tend to underdiagnose rosacea, because we find every evidence of it on the ocular examination, but the dermatologists don't necessarily corroborate that. So I think there again, the doxycycline is a great help, because it helps them for both. So.
Shall we go on to Ashok? Would you introduce Arun?
Yes. So privileged to introduce Dr. Arun Baweja. I've known him for almost a couple of decades. He was initially in the Indian Army, and then he was a colleague at the Mohana Institute. He's been a very prolific cataract and refractive surgeon over the last quarter century. And he's been an office bearer of the Delhi Ophthalmological Society for a long time. And he's passionate about teaching.
Thank you for those nice words, sir. I shall be talking of new treatment approaches of dry eye management. And I think a lot has been said about dry eyes already. The increasing prevalence of dry eye is dependent on the increasing lifestyle population, consumption of medications, increase in number of people wearing contact lenses, and computer vision syndrome, increase in the patients undergoing refractive surgery, and the pollution. Now, there's an unstable tear film leading to squamous metaplasia, keratinization, and mucus. Is characterized by tear deficiency or excessive evaporation, tear film instability, rapid tear breakup, ocular surface pathology, or ocular tissue damage from inflammation and immune activity.
Arun, please check your internet connection. Your voice is getting drowned out at times.
Okay. These are the dry eye symptoms, which include redness, excessive mucus, secretion, halos, epiphora. Is it clear now?
Yeah,
Yes, better.
Thank you. So classification of dry eye is symptomatic is dry eye disease or non-dry eye disease. This is dry eye is aqueous deficient or evaporative dry eye, and non-dry eye disease can be lid related or which can be MGD or idea blepharitis as has been described, or the other factors. Diagnosis of dry eye depends on patient's history, signs, symptoms, ocular history, medical history, and physical examination, which is very important. Patient history, we all know what signs and symptoms, exacerbation and environmental conditions, what medication is the patient currently taking. Medical history is what does the patient suffer from any dermatological disease? Is the patient suffering from any atopy or ocular allergies? Has the patient undergone through menopause? Has the patient experienced any trauma involving chemicals? And does the patient suffer from any autoimmune disease? Advanced diagnostic tests consists of tear breakup time, that's the interval between blink and appearance of dry spots, diagnosis of aqueous tear deficiency and Waypham gland dysfunction, less than 10 seconds, more than 10 seconds is considered abnormal, ocular surface dry staining, rose bengal, fluorescent, lismanin, stain areas of cornea, conjunctiva, mucous degeneration and damage. Now, impression cytology mapping. This is showing a healthy, this is a moderate dry eye. Schirmer test, which is the most important test, filter paper strip used to test tear production over 3 to 5 minutes. Less than 5 to 10 mm is considered abnormal. And tear clearance evaluates tear flow across ocular surface. Decreased tear clearance, risk factor for ocular irritation. Diagnosis of age-related dry eye with Waypham gland dysfunction, decreased and conjunctival sensation. This is showing a Schirmer's test, wet area and a dry area. This is a rose bengal stain and a fluorescent stain. Now, this is the diagnostic algorithm showing the dry eye, the rising questions, risk factor analysis. I think Tushar had also mentioned about this. So, diagnostic test, non-invasive, osmolarity, ocular surface staining, tear breakup time greater than 10 seconds, less than 10 seconds. How severe is the dry eye discomfort? How severe is the eye discomfort? Do you have any mouth dryness or swollen glands? How long have been your symptoms and triggering event? Is your vision affected or does it clear on blinking? Are the symptoms or any redness worse in any eye? These are all the questions to be asked in detail. There is classification of dry eye. Mild dry eye, occurrence of symptoms occasionally. Moderate dry eye, occurrence of symptoms daily but not frequently. And severe dry eye is occurrence of symptoms daily and frequent. Now, new treatment approaches of dry eye management. Warm compresses, artificial tears, punctal plugs, oral doxycycline. It's all been covered by Dr. Aditi and Cyclosporin. Newer drugs are lifitegrast and tavolaramide, lateral bridge plasma, albumin precursor, non-invasive intranasal lacrimal neurostimulator, salivary gland transplantation, and stem cell therapy. Now, DUSE 2 recommends daily eyelid hygiene. Why eyelid hygiene is important? The important role the eyelids and eyelashes play in the treatment and management of dry eyes often sometimes overlooked. Eyelids and lashes function to protect our ocular surface and promote a healthy tear film. Daily eyelid hygiene is vital in treating dry eye symptoms and preventing infections. Eyelid hygiene beyond blepharitis. By preventing the buildup of bacteria, proper eyelid hygiene prevents blepharitis and resulting possibility of Demodex. Keeping the eyelids and eyelashes clean is also vital in protecting the veins of black that line our eyelids and help secrete our tears. Eyelid infections, allergy worsen the symptoms of dryness, but can be a serious threat to the ocular health and puts the corneal tissue at risk for damage. Tea tree oil, as has been mentioned, based eyelid wipes are sometimes better options, and Oculeaf offers one of them. This is healthy eye. This is the eye with dermatitis. This is Oculeaf soft eyelid cleanser and Oculeaf eyelid wipes. They are tea tree oil based eyelid cleaning projects and complete eyelid hygiene. You can start with using these if this works. Otherwise, you can move on as Dr. Jaya had shared. Eyelid cleaning beyond dry eyes. Daily eyelid cleaning for patients with blepharitis, MGD. High importance of preventive ocular hygiene and eyelid hygiene for surgical procedures. Artificial PEA, liquid polyols, hyaluronic acid, multi-drug combinations, inserts, and preservative-free options. A multi-ingredient combination blended in single eye drops, hyaluronic acids, CMC, osmoprotectin, that is glycerine, erythritol, L-carnitine. They promote, protect, and restore the ocular surface integrity, result in most effective treatment of dry eye syndrome. HA 0.1%, CMC 0.5%, and osmoprotection. They reduce cellular stress and improve integrity of the ocular surface. New approach to dry eye treatment, now supported by due to recommendation. First, eyelid hygiene, followed by lubrication. This will prevent buildup of bacteria and virus. Clean eyelids will protect billions of glands to have normal tear secretions, and multi-ingredient lubricant drops offer superior effect than single ingredient drop. Thank you for your kind attention.
Thank you, Dr. Baweja.
Thank you, sir.
And there are some questions from the audience. Arun, what complications could arise if I leave eye dryness untreated? I don't want to treat my eye dryness. What will happen?
It will result in chronic blepharitis, and even keratitis or keratoconjunctivitis can be a sequel. So,
yes.
I think it should always be treated.
And can I still wear contact lenses if I have dry eye is a question from the audience.
I think if you have an active MGD disease, you should wait or wear extended wear contact lenses. Those would be better.
To elaborate a little bit on this, if you have contact lenses and you have dry eye, and it depends on whether you have symptomatic dry eye or the eye surgeon has picked it up. Many times you find that your contact lens wearing time is reduced. That's not because the lens is tight or is not fitting well, but because there is now dry eye associated with contact lens wear. There's actually a disease called CLIDE, contact lens induced dry eye, CLIDE. So you need to be very, very careful in these cases. You need to manage your dry eye well before you can go back to the contact lenses. And if you're wearing the conventional contact lenses, might feel better with the disposable contact lenses, and the faster you dispose, the better your eye will feel, till you go down to the daily disposable contact lenses. That might help you if you must wear the contact lenses. But you must treat both the blepharitis as well as the dry eye component very vigorously if you want to continue wearing lenses.
So most of these dry eye patients are associated with the computer vision syndrome. Their screen time is much higher.
Yes.
Plus, when choosing a contact lens, I think we should choose a contact lens with a high decay value, and
Yes.
a daily contact lens would obviously be the contact lens of choice.
Quite right. Quite right. If there are any other, one other which you already answered, Arun, is that can excessive reading and TV or computer viewing cause dry eye?
Screen time, yes.
Covered that. Yeah.
Sorry, I'm interrupting. Can I request Dr. Bhaveja to remove his slides, please?
Stop share.
Can you stop screen share?
Just stop it.
Yeah. So, Dr. Arun, the question from the audience was, can excessive reading and TV or computer viewing cause dry eye?
Screen time, yes, it causes dry eye, definitely.
Yes, I think you did cover it. Yeah.
These are patients who have excessive screen time. They are not the normal ones. They have, I think, 12 hours in the office plus their mobiles. So they are throughout the day on the screen.
Right. Okay. Are there any other questions from the audience, or can we ask
Added
Ashok?
to this, I would say, sir, their eye hygiene is very poor because they are extremely busy. So their eye hygiene happens to be very poor.
Okay.
I have one comment to make if I have a minute.
Yes.
Sure.
So the question on contact lenses which came up. So the other side of that is that actually patients who have moderate to severe dry eye, especially the ones with the severe Sjogren's syndrome and all, we can actually use mini-scleral contact lenses as therapeutic lenses for them. They really act as good tear reservoirs, and you would see that the quality of life phenomenally improves. So the question which came on contact lens, of course, the routine soft contact lenses, yes, there are you have to see and assess and decide. But when you have a patient with a severe dry eye, with a rheumatoid arthritis, who's got n number of filaments and keeps coming with that again and again, these are the patients where the mini-scleral contacts with the, which act as a reservoir, they work beautifully.
Aditi, not the mini scleral so much as the actual scleral contact lenses, which are 18 millimeters. They are the ones which have the cup in which you can put the normal saline and you can wear it. The only issue is the expense. They vary from 60 to 90,000 per contact lens. So it's definitely very useful for those with very severe dry eyes where they can't open their eyes. It does wonders for photophobia as well. Tushar, there was earlier, you were talking about the lipid layer, and I think Ashok asked whether there was some lipid available. As correctly said, we don't have lipid in our country in the form of eye drops as they have abroad. But many of our patients have been using various oils like castor oil in their eye, olive oil, castor oil in their eye on home use, not recommended by us. Ghee is something which has been used. Desi ghee has been used for quite some time. And some of these do seem to work, and they don't have the bad effects that we feel they will have because these are not ophthalmic preparations. So it's something to be kept in mind. Yeah.
Okay, true.
There are some more questions for photophobia. Which topical drug can we give? Yes, I mentioned this, that I find that for photophobia, topical chloroquine, which is available commercially as UV lube eye drops, can be given maybe 2 to 4 times a day. You can use it just twice a day is also sufficient. You need to continue it for about a couple of months, then take a break, and then you can re-continue. It seems to work. And Dr. Suman has asked, please tell us the role of non-steroidal anti-inflammatory drugs. I think we've dealt with this, that if you're talking about the NSAIDs, like traditionally the bromphenic and the nepafenic, those are a big no-no for ocular surface and MGD. But what Aditi, I think, was referring to was the cyclosporins and the others, which can be used, rebamipide and other drugs. Yeah, tacrolimus. These are all non-steroidal, steroid-sparing agents which can be used. Somebody has asked about chloroquine. Yeah, we've answered that. I think most of the other questions have been covered by the speakers. Jaya, you wanted to say something?
So most of us are cornea people over here. I would like to know Dr. Grover's view on Demodex. Does he take it seriously, or I mean, what is his view on that? The cornea people definitely take it.
It is definitely an underdiagnosed condition, just as meibomian gland disease is. The awareness for meibomian gland disease just came about in the last 5 years or 7 years only, and then the therapies came in. The Demodex has come into limelight within the last couple of years, but both are grossly underdiagnosed entities, and you need to be aware of them, look for them, have a high index of suspicion, pick them up and treat them.
That's true. I mean,
You seem to have frozen.
But is it frozen?
Also, I would want to ask the panelists what they are doing about omega-3 fatty acids orally now. Are they giving it? Are they not? Because it's controversial and there's not much consensus.
I'm using omega-3 fatty
I
acids.
am still using it, yes.
Okay.
I'm also using it.
I'm still using it and not very convinced by the DREAM study.
Okay.
Okay, now the $1 million question.
Systemic effect as well.
Okay, the $1 million question. Which lubricant in which situation? What is the role of so-called preservative-free ones? When do you use them? And the true preservative-free ones used in those unit presentation, UNIMs. So where would you choose which one?
Ashok, are you directing it at anyone?
Begin with
Because
you.
I want to earn that $1 million.
In ocular allergies, recurrent ocular allergies, especially, I think preservative-free should be preferred.
Okay. No, not just that. Choice of your compound and your strength. Start with Quresh.
Yeah, Ashok, actually you can have a whole, and we've had a whole webinar just on choice of lubricant.
I know,
So
that.
I won't go into all that, but the point is that
the point is I want to see your art of summarizing things.
So I'll tell you, the whole issue is that almost every drug company which makes lubricants now makes them with disappearing preservatives or preservative free. None of them are adding the BAKs and others into teardrops anymore. So we are talking only about difference between disappearing preservatives and preservative free. So if it's a mild to moderate dry eye, when you're using of the drops is 4 times a day or less, you can get by with the drugs even with preservatives or the disappearing preservatives. But if you're going to use it and that, I would be my patients would be more comfortable with Union, which is the preservative-free drug, or in those novel bottles where again you can get a truly preservative-free drug. They seem to do a little better than the ones with even the disappearing preservative.
Tushar, would you answer something?
As far as choice of drug,
also depending on affordability of the patient.
Oh, that comes last. First you choose and then you decide whether the patient can afford it, which is the right one for this patient. Would you choose hyaluronic acid always, or CMC, or something else? Yeah.
Would you want me
actually even HPMC is still used by me because some of my patients are happier with HPMC than CMC. Some are happier with HA as compared to CMC. So every patient is different, and how they respond and how their eyes soak up the teardrop is. So it's a process of really trial and error. But I do go by by whether it's an evaporative or an aqueous deficient. If it's aqueous deficient, my preference would be for a CMC type. It's the evaporative lipid deficient. My preference would be one which will stay longer, which is the C type of drugs and the generic lookalikes, and the HA type of drugs, which will tend to stay a little longer in the eye. I have almost given up use pure CMCs because now you get CMCs with the osmoprotectants available at the same price. So if I have to use a CMC, I would prefer to use one which has got osmoprotectants as well.
Tushar,
as Arun, there is a lot to be said in combination drugs. Yeah.
You were saying something, Tushar.
No, I thought you were asking me something.
So give your rationale for your choice.
Yeah, so I think for me also, for a case with very mild to moderate dry eye, I think CMC 0.5 or 1% is adequate. And somebody with severe dry eyes, I would go for sodium hyaluronate. And additionally, I would also want to add a lubricant ointment or a gel at bedtime, particularly, because I think that helps.
A very underused.
I have a question for you, sir.
Yes.
Where would you like? Where do you use tacrolimus?
Tacrolimus, I don't use too much in the garden variety of dry eyes. I use tacrolimus more for allergic conjunctivitis patients as a steroid sparing agent. Sometimes in corneal graft patients as a steroid sparing agent. I don't use it in too much as far as simple dry eyes are concerned.
I also find it useful in superior limbic keratoconjunctivitis cases.
Yes, yes, yes. True.
Getting rid of the steroids.
I also want to add another drug which we haven't talked about, but which I like quite a bit is trehalose. So trehalose has got an anti-inflammatory action as well as a lubricating action, and it's the drug which preserves the cell life of the ocular surface cells better than any other. So if there is apoptosis or premature cell death because of dry eye, trehalose is the one which keeps those cells active and working the longest. So it's again very underutilized and even under marketed by the companies which deal with it. Yeah.
So Kuresh, one drug has been left out of all the discussion. What about the role of cyclosporins now? How often do you use them now?
I am a great fan because I was one of the earliest to start. I used to get it smuggled into Bombay when it was not available 25 years ago. So I feel that cyclosporin is again underutilized. So in any patient who has got primarily an aqueous component dry eye and who's in the DUSE classification in grade anywhere up to grade 2 or 3, it works very well. You need to continue and persist with it and tell the patient that the effect will come in a month, 2 months sometimes, but don't use it. I find that because it's expensive, people tend to use it in stage 4 of the DUSE classification. When all the lacrimal glands have dried up, you're flogging a dead horse and then you give cyclosporin a bad name. So simple 0.05%. I don't go for the higher strengths. The 2% and the others are used for my allergic conjunctivitis and others. But for a dry eye, I would still stick to 0.05. It works as well as the higher strengths.
Jaya, what is your opinion on cyclosporins? How commonly are you using them?
Even I do use it. So I mostly like for surface inflammation, if I have put the patient on topical steroids, I also put them on cyclosporin at the same time because the topical steroids get withdrawn, the cyclosporin continues.
The other aspect is when you, how long do you keep them on? Unlike chloroquine, is the duration shorter in chloroquine? Is the duration longer in cyclosporins? What is your?
If it's working at least 1 year, then you can have a washout period and see if the patient becomes worse. Then you may continue it for another year and so on.
Yeah.
So you need to, I would go with blindly at least for a year.
What about chloroquine, Aditi? How long do you use chloroquine drops?
So I have really not used chloroquine quite a lot. Probably I must have used it in a very handful of patients. And as Dr. Muscati was mentioning, so I have used it typically for 6 to 8 weeks. I haven't really tried it more than that. But yes, cyclosporin I use a lot. And typically I've seen...
You should not.
Yeah, and typically I've seen cyclosporin when given with steroids works the best. Because, by the time, because cyclosporin itself causes a lot of stinging and, it's an irritant in itself. So when you have a loteprednol or a steroid cover, the loteprednol can work, take care of the active inflammation. And by the time you taper it off, cyclosporin is fit enough to take up the action. So at least I feel when they work better together and then you can taper off, stop one and then continue the second one.
Tushar, you were doing a study, a research project or thesis project on chloroquine. Any preliminary observations on that?
Yeah, so far we have not really analyzed the data completely, but we're doing it in post-LASIK eyes. So that will be interesting to see how it shows up. And we had in the study protocol used it for a month after LASIK. So we had not used it for 2 months, but we had used it for a month.
So my choice between the tacrolimus and cyclosporin would be tacrolimus. One, because of the concentration what has been advised for the cyclosporin, it's not available. Make a formulation for that, and I have used tacrolimus extensively, and it has helped the patient a lot.
In the dry eye, what kind of dry eyes?
Yeah, so basically in allergic.
Yeah,
Leaking.
allergy.
Yeah.
Tacrolimus allergy definitely is there. Yes. Kuresh, observations.
I think we need to hand over the screen to Parul to conduct a poll.
Hello
Parul?
everyone. Here is a small survey. Just give me a minute. And everyone should go to www.menti.com and the system will ask you the code. The code is 26893. You can use your mobile or computer browser for www.menti.com and the system will ask you the code. The code is 26893. I will wait for 2 minutes so that everyone can enter in our survey.
Yeah, Parul, you can.
Let's get started. First question, is this webinar helpful with broader perspective of blepharitis, MGD and dry eye management? I can see responses coming in. And it is good to hear that 100% of our audience finds this webinar useful and helpful. All thanks to our faculties. Thank you so much for your nice talk. Now I will go to the next question, second question. Do you think that eyelid and face hygiene needed in the current COVID scenario? I can see responses coming in. Wait for a few more seconds. 3, 2, and 1. 96% of our audience think that eyelid hygiene is more important than ever before. We agree too. Now I will go to the third question, the last question. Is multi-ingredient lubricant which contains hyaluronic acid, CMC and osmoprotectant superior to individual CMC or HA? Your opinion. Before completing the question, I can see many responses coming in. 3, 2, and 1. 76% of our participants think that multi-ingredient lubricant is superior than individual CMC or HA. We agree too. Thank you so much for participating in our survey. I hope you find it interesting as we did. Thanks for the hearts. Thank you so much.
Thank you, Parul. And with that, I think we come to the end of the session. All good things must come to an end. And we'll wait for more similar webinars because this is a topic which really needs to go across to everyone. And I think we've answered approximately 80% or 90% of all the questions that we had. Ashok, if you have any closing comments?
Just to say that, as I said, this is a subject that touches us all. So we should keep refreshing our thoughts and keep exchanging our ideas on the subject, and had a really great time being with you and with all.
Thank you.
And thank Waypham.
Thank you, Siddharth, and thank you, Waypham. Yeah, thanks all.
Thank
you.
you very much. It's always
And
pleasure,
thank you,
Doctor.
audience.
It's always pleasure to be there with you all together. And I think it's almost 2 hours that we are, and it's looking very live, very interesting. So there have been very nice audience that we have around. So I think it's a time to thank everyone together. There's a lot of audience who are seeing it on YouTube and Facebook, as well as on live on Zoom as well. So we have a very interesting discussion, Dr. I think there are a lot of new dimension which I saw that has been expanded, and especially a discussion on Demodex with Dr. Jaya and Dr. Hitendra and everyone has initiated, and we got into a little more deep and detailed discussions on it. It was very interesting because I think what my experience also say that there are a lot of doctors across country now, they have been noticing that a lot of patients with the Demodex, they keep treating recurrent blepharitis and MGDs. And when they address Demodex, the results are better. So I think that's very interesting, doctor. And also the important part again, doctor, remain that hygiene and preventive care is the need of the hour again. Like there has to be better lid hygienes. That will itself prevent a lot of infections and recurring problems. So it's very pleasure to bring this, host this webinar together with Dr. Grover, who is very, very renowned ophthalmologist in the country and internationally. As one of the very nice speaker always. I mean, we find always is adding a lot of big values, and is a real teacher. Dr. Maskati again for making it a big discussions around and making it very nice. Thank you very much, Dr. Hitendra, Dr. Jaya, Dr. Aditi, and Dr. Arun Bhaveja, and Dr. Tushar for really enlightening us with a lot of new ideas and thoughts. It was very interesting, Doctor, for Waypham to bring this webinar.
That's one question I just want to ask everyone.
Yes.
Well, it's not related to this. How many of the operating surgeons are taking HCQ? Dr. Grover, sir.
Yes,
I am.
regularly taking it, 8th week now. And I'm sure all the trials which exaggerate the side effects are commercially driven.
Dr. Maskati, sir. Yes, has he left?
His video is going off. I think
ICMR is quite positive about it, and all our rheumatologists are quite positive about it, that they've been using it for years together in their patients of rheumatoid arthritis and SLE without any significant side effects. And the ICMR study has come out quite conclusive regarding the role in prevention. We're not talking about therapy.
Right.
So
What's the dosage you are using?
500 milligram, 200 milligram, 2 tablets every week. Started with a loading dose of 400 twice a day, and continuing with 400 milligram every Wednesday.
400 mg per week is what.
Yeah.
And this would go on for like how many weeks?
They said after 7 weeks, you do continue, but get an ECG done to check your QT interval. That's only because of the
Cardiac effects.
international, some
12 weeks is being suggested here.
So and that's why ICMR put that proviso in, but it is not really a significant side effect to generally healthy people.
Okay.
Any comments, Hitendra?
No, I have not used that.
Not used.
Your heart is very strong.
So I think, Doctor, we come to the end of this session, and thank you very much. And we would certainly like to have more such programs in time to come. We are very encouraged to host such kind of webinars, which adds academic value and really transmit a good information, knowledge or across. Today, it has been viewed by over 400 people. And so it was very interesting to see that. So because there were almost 300 plus people on the YouTube, been continuously there for a longer period. And also here also almost like 70, 80 people. So roughly around, I see more than 400 people right now. And later, I'm sure that the viewers will go up in thousands of this program. Thank you very much for
Very
being here.
nice.
Thank you, all of you.
Thank you.
All the
Thank you.
speakers
I really
and
appreciate
the
it.
audience. Thank you.
Nice.
Thank you, sir.
Thank you, sir. Thank you very much, sir. Thank you.